Hey guys, welcome to the Fellows in Training this article discussion hosted by three doctors of physical therapy, where we will be reviewing and discussing articles pertaining to everything physical therapy, strength and conditioning, exercise prescription, nutrition, and everything in between. My name is Michael Dela Cruz, and I'm accompanied here by my two great colleagues, Dr. Tristan Barrera and Dr. Darian Fernandez. With that being said, Darian, how are we doing today?
What's up, man? Doing great. Glad to be back. Tristan, how are we doing?
Doing amazing. Got a really good discussion here. Really nice topic to go over. So I'm really excited about today's series.
So, for today's episode, last episode we talked about the right exercise for directional preference. Today we'll be doing talk about the neurophysiological effects of a single session of a spinal joint mobilization. Does the effect last? It's a systematic review. And with that being said, Tristan, take us away.
Yeah, so this systematic review by Hedges and colleagues was done in 2011, published by the Journal of Manual and Manipulative Therapy. It's a really great article. The introduction really gives a good outline, a really good precursor for what is going to be eventually talked about. I love when they talk about on page 1 the neurophysiological effects that can be found at the site of treatment and areas remote to the local area of treatment. They talk about the effects being pain-related measures such as increased pain or pressure pain threshold, decreased visual analog scale pain rating, increased pain-free grip, changes in skin conductance, changes in skin temperature, and improvements in range of motion with neural tensioning. I thought those were a really good precursor just so that the reader has a better understanding of what type of neurophysiological effects have been studied and what type of neurophysiological effects can be looked at in the clinic. I thought that was really awesome. Furthermore, they talk about these effects. Are they important to the patient, right? So despite being little correlation between impairments and functional limitations, are these impairments, signs, and symptoms, are there even something that we should be looking at a daily basis? And the reason why we should is because when we talk about functional improvements, those take days, those take weeks more likely. And with that being said, we use impairments, we use symptoms as proxy measures so that we can understand complex constructs like function a little better. It also, for two big reasons, alleviating impairments does two good reasons, as in giving us a reason that patients seek care. So they're seeking care because of their gait impairments, their painful gripping, their inability to go through ranges of motion and not feel neural sensitivity. And then two, alleviating these impairments gives us as a clinician a great indicator that our interventions are being used correctly. So I thought it was really awesome to see this in real life, to see this in the article being portrayed very simply to a reader, to a young clinician that could take this and run with it. At the very end, they talk about the purpose of this systematic review was to examine the temporal nature of the neurophysiological effects of passive joint mobilizations when used in isolation of the spine in human subjects. So very simple, very easy to read. I thought it was really awesome.
Yeah, you pretty much said everything for the most part, everything I wanted to say. But this article is, I think, a great one to read, especially for all the manual therapists out there, people that utilize manual in their treatment, because we do all these different things, but are we really understanding what's going on, right? And you'll see later on in the article, once we start talking about it, they even noted that it helps aid the shift from a pure biomechanical model to taking more of a multimodal approach. But we understand and we know nowadays that whenever we do a mobilization or joint manipulation and stuff like that, yes, while we can feel movement occurring within a joint, doesn't necessarily mean that we're realigning the joint. We're not like putting things back into place, but diving in deeper into what's really happening, exploring what's happening within the cortices to create these meaningful changes that allow us to elevate our game as therapists and create that window of opportunity to create change within the system. Then you show the patient, hey, we reduce your pain. Let's get you to move better. Let's do these exercises now. So I think this is a great article, and I'm going to really enjoy the talk about this one.
Yeah, I would agree. I think Mike did a really good job putting this article in context. And I think, yeah, Tristan, you kind of covered a lot of what I was going to say. But I think what's really cool about this article is how it really summarizes a really big topic in a short introduction. If you look at other articles on this subject, they're lengthy, they're deep, they're really hard to unpack essentially. This wasn't. So I think if you're trying to like get your first taste of what is the neurophysiological effect, then see some evidence for how to actually use it, this is probably a great start.
Yeah, I couldn't agree more. And I think even when you look at the last paragraph on page 2 of this article, it talks about Coronado and colleagues reporting a single session of an HVLAT and its demonstrated neurophysiological effects. However, quote unquote, short lived. We've talked about our beef with short lived, long term, short term. What exactly does that mean in the literature? However, if we just take a step back and we focus on exactly what they're studying, this was one of the first articles, and even Coronado was one of the first articles that started looking at neurophysiological effects just with no other PT things. Obviously, when we treat in the clinic, we're not just doing joint mobs. We're not just manipulating someone and then leaving. We're layering that with other higher level interventions and things of that nature so that these lasting neurophysiological effects can begin to start to layer themselves on in later sessions. But again, this is one of the first just opening dialogues of what NPE is, and I thought it was really amazing to see it. Any other things that we want to talk about before we head to the methods?
Well, just like you mentioned there, and with the Coronado study, how they talked about short term and the ongoing debate with manual therapy, that it only has short term versus long term effects. Tristan, to your knowledge, in the literature, how long does 6 weeks last? It lasts 6 weeks, right?
Yeah, of
The
course.
short term is about 6 weeks in the literature. Sorry, meant to say that. And that's what I think a lot of people miss
Mhm.
is that 6 weeks is a long time. We
Yeah.
can create a lot of change and lifestyle changes and habits within 6 weeks that translates into the long term. And if you're a user of manual therapy, understanding that and utilizing that to, again, as Tristan said, layer it, you're going to be able to create all these different outcomes and change within a patient that are really meaningful and get them to where they need to be. So I'm good to move on to the methods. Let's do this.
Yeah, so in the methods here on page 2, they talk about the grading systems that were used, how they're evaluating different things. They talk about the inclusion exclusion criteria, their search strategy, their review process as well. And it's really simple, really straightforward. When they talk about a section of quality, strength, and importance assessment, that's when it gets a little harder for the reader to understand. You might have to read that paragraph 1, 2, 3 times, but we're going to break it down here for you so that we could really get a good idea of what exactly they're looking at when they're reviewing these other studies, right? Because it is a systematic review. So when you talk about the quality here, they're looking at quality from high, moderate, low, and very low quality. They're looking at the high quality that suggests that further research is unlikely to change the effect size of the intervention. And that's important because they're describing a research article that is of no needed further research. Now, when they talk about high quality, they're scaling this quality. So you're looking at a 9 and an 8 being high. You're looking at moderate quality being 4 to 7 and low quality having scores of 0 to 3. Now, what gets a little confusing is they label these as a grading scale A, B, and C. So obviously high quality is A, moderate's B, low quality C. So that's how they're using that grading scale. Then when they look at the strength of the evidence, they're using it as a 1 or a 2. It's a dichotomous strong or conditional / weak evidence. And then furthermore, when they evaluate the outcomes, right, the importance of what is actually being evaluated to the patient, not to us as a clinician, but to the patient, they use a scale of importance, 1 being critical, 2 being important, and 3 being not important. And furthermore, they talk about a little bit that no studies that they saw had a grade of 1A1, meaning critical, high quality, and 1 strong evidence. So that's what they talk about with the method section there. Anything in the method sections that y'all guys wanted to talk about? Anything with the flow diagram of article selection or anything like that?
No, nothing too deep. I just think it's cool how they selected not just one criteria for the articles, how you kind of have like in the same way we cluster special tests, they clustered uh, assessments for these articles essentially to make sure they really were strong. So they really did vet them. And I think that was important because if you look at the number of articles, it only was 10, right? That they ended up actually using. So I think this criteria becomes more important to justify the strength of those 10 articles and why they chose them.
Yeah, and we're going to talk about that when we take a deeper dive of those articles. But yeah, I think they were very thorough, right? And sometimes being too thorough does get you in a little sticky situations, and we're going to talk about that a little later. But yeah, they wanted to make sure that every T, every I was dotted, every T was crossed, and they really took a lot into consideration with these literature searches. Anything before we go and head on to the results? No. So all of the searches, they looked at over 346 articles. They have a figure 1 that's beautifully displayed of kind of like their thought process and how they weeded out and resulted in those 10 articles being reviewed. 6 were in the cervical spine, 3 were in the thoracic spine, and 1 was in the lumbar spine. So that's kind of the articles that they were looking at as far as joint mobilizations. They have study characteristics and a summary of each article in table 2. While one study examined patients with neck pain and one study examined patients with lateral elbow pain. So they did look at other areas of treatment, but still focusing on the spine. So that would be a cervical spine one, neck pain versus elbow pain, but still looking at the spine. And then as well as both studies that they looked at, in specific, they were looking at studies that had 10 minutes to 5 minutes of joint mobilizations. They looked at oscillatory mobilizations to the cervical spine. So different types of mobilizations were being used, different lengths were being used, different neurophysiological measurements were being used, right? So they really had to weed out exactly what these articles were looking at. And I think that's why the quality, the strength, the evidence of importance was such a vital component to this article, is because they had to look at so many things. Anything for you guys?
I think what stands out to me is like how there wasn't as many studies that were viable with patients in pain. I think that's really important because that's what we're doing these techniques on people. That those are the population that we're using these techniques on in general. So I think that's important that we know that we understand that a lot of what even inspired the study is anecdotal evidence, right? And that's still important, right? We're not looking at that in like a paper format, but it's still important to consider that what is missing here is still a validation of what our expert opinion is telling us every day.
Well, I agree to a certain degree. While we didn't see as much of that painful population that we would have liked to see, again, we have to remember that the neurophysiological effect stems beyond pain modulation. It's also the neurofacilitatory effects that occur within a muscle, within temporal summation, all that stuff like that. And their let's just, for lack of a better term, their rate of conductance to produce a meaningful contraction, to produce different movements. So although they didn't have that painful population, they were asymptomatic, right? They still showed changes in their neurophysiology and the ability for the joint mobilizations to affect their presentation, whether they be in pain, can't do certain movement, joint motions restricted. There's still some sort of change, and that's what I can appreciate about this. I understand what you're saying. That's exactly what I would like to see too, right? Because we get someone that comes in hot and they're in pain, we want to calm their pain down. But also from the standpoint of, let's say, an athlete that's coming in for like a tune-up, how can we use that neurophysiological effect to increase their performance?
I think that's important to add. I mean, when you look at the full picture, that's definitely true. I mean, wellness patients are also a big part of what we do as PTs in some populations or some settings. But even beyond that, I think the fact that you have a demonstrable effect in asymptomatic people actually is a testament to the power of the technique, right? You can not even be in pain and still get positive benefit out of that, as you put. So it's a really good addition there. Thank you.
Yeah, and I think so furthermore on page 3, when they have that italicized section of quality and strength of evidence importance of outcomes, I do want to add that table 3 has a nice good summary. They say that 6 out of the 10 studies were of high quality. So that's your 8 out of 9 scale, or that's your A. And the remaining 4 studies were of moderate quality. And they said most of the moderate quality studies were downgraded due to lack of subject randomization and questionable or absent allocation concealment. So again, they were very, very thorough when looking at these articles. They were not letting articles not go unturned. They were looking at everything from research design, intervention groups, control groups, outcome measures, results, and they really took their time to look at these 10 articles. So I do appreciate that. Anything before we head over to the discussion?
No, we're good.
Nope. So here in the discussion, I like how they talk about the implication of studies looking at neurophysiological effects. They talk about the sympathetic nervous system response that is demonstrated by some of those proxy measures that we're looking at. We're looking at, the conduction, the skin temperature, things like that. And then they do say that that sympathetic nervous system response must be because of the dorsal perioctical matter of the midbrain when stimulated. It's stimulating of that DPAG produces analgesia, sympathetic excitation, and motor facilitation. So that's where we get that inhibition, that analgesic effect, but also that motor facilitation, hopefully clearing up some of that motor patterns and things like that when we layer on our treatment. Again, we layer on our treatment. So that's very important to understand. We're not just going to pop someone or do some joint mobs and think, all right, we're all done here. Shout out to Terry from NIOMT. We're going to layer on with some neuromuscular re-education. Anything that you guys want to add in as far as the discussion, but I do want to take a look at that table. So let's not forget about that. I want to look at table 3, but anything from the discussion you guys want to talk about?
So pretty much here, I think the main thing here is the inclusion of noting that the para-addictable gray matter is of high importance, because it's very nice to see that dating back to 2011 and looking at mechanisms of manual therapy, we're including these pain generating sensors in the brain. We know it comes from different cortical regions. We have these main ones that are highlighted, and then Bialowski in 2017, 2018, revised in 2018, goes a step further to then discuss all the manual therapy mechanisms as to how it influences pain modulation. And it's again mentioned, the DPAG is mentioned again. You get the rostral ventral medulla, you get the anterior cingulate gyrus, right? So the fact that manual therapy and these mobilizations in just a short bout of treatment can influence these regions, I think is outstanding and should be implemented to our plan of care. Like you said, start to layer on top of that.
Yeah, I agree. I think that's it's important with the layering, and I think when you talked about earlier, like we were about to talk about buy-in, I think, and what's really the power of manual therapy and how to use it. And there's so many layers of pain and physical therapy, but let's talk about the first layer. What about that first treatment? Well, what's the best way to get them to come back? Make them feel better, make them a little stronger for 5 minutes, make them move better, right? What's the fastest, most efficient way to do that? And for a lot of people, it's manual. It's giving them a little mob. And we're not even saying you have to do a manipulation. This is talking about just mobilization, only one session. And then that goes into what's short term. Fine, okay. If short term is 6 weeks, that's not that short, first of all. And then second of all, you can do it more than one time. You can keep compounding that 6 week period and just extend that. And you just layer on these little proxy measures of minute treatment. It's minute, but it's significant when you add it up. So I think that's kind of what you're saying there.
Well, that too, just to go on top of that, before we continue, you're getting that buy-in. You're showing that patient that you have the ability to create a within session change, which is critical to their prognosis, right? Because if they don't believe that they're going to get better, and you show them that you weren't able to change anything within a session, the prognosis just drops. Right? You need that rapport to be established. But even then, manual therapy, right? We're talking 6 weeks to short term. I mean, I'll ask you guys, how long does it take to create changes from a strength and conditioning session? To my knowledge, about 6 to 8 weeks, right? So if we're coupling strength and conditioning with rehab principles, we're creating a solid foundation where these patients can really, grab this thing by the horns and create the change that they want to make,
Yeah, and everybody wants to talk about strength and hypertrophy, strength. We need to get them stronger. How do we do that? We need to get them, a little bit of hypertrophy, loss of muscle mass and things like that. The muscle mass, strength and conditioning research Some are suggesting it's 8 to 12 weeks. So that's a long time. Not a lot of patients do we get to see for 12 weeks. So when we talk about strength, if we could improve some type of facilitatory effect, some type of muscle activation, that is important. And speaking of importance, I want to head over to table 3, summary findings on page 7. So a lot of these importance of outcomes in clinical decision making, remember, important to the patient. 1 is critical, 2 is important, 3 is not important. Look at all of these grading, a lot of 3s here, a lot of 3s and 2s, no 1s, right? And what were they looking at? They were looking at decrease alpha measurements of saliva, increase skin conduction, skin temperature, things like that. Yes, we agree. Maybe those things are not something that a patient cares about, but it's telling us that we're having a neurophysiological effect. And if you layer your treatment correctly, you can make some lasting improvements with that session. You can make some really good things. I wasn't able to reach that high. When I reach that high, I don't feel as much pain. Taking someone's pain from an 8 out of 10, a 7 out of 10, a 6 out of 10 that they've been feeling for 2 months, 3 months, acute on chronic. I felt this since my mid-20s. I'm now 45 years old. I've been in this pain for 20 plus years. Taking that pain to a 2 or a 3, that is clinically important to me. So again, they were very harsh on their summary findings, on their quality assessments, on the strength of the evidence, as they should be. But I think it comes with a caveat that just because they were measuring things of neurophysiological importance or measurements, proxy measures, you could use those proxy measures into somewhat of function within that session. So just keep that in mind when you're looking at that table 3 summary. Anything about the limitations that you guys thought was important before we head over to the conclusion?
Well, even before we go into that, if we look at the discussion again on page 7, right? This is what sticks out to me. And sentence says, however, the temporal nature of this SNS effect, with the exception of analgesia produced by cervical mobilizations in one study of moderate quality, appears to be mostly 5 minutes or less. So we know that for one session, you're getting about 5 minutes of a good cascade of neurophysiological effect. Who's to say that this stays like this all the time? We don't know. But if we go any further, we see again, because I mentioned it before, that this systematic review is important in driving the paradigm shift in manual therapy away from a strict biomechanical model and more towards a comprehensive model that recognizes peripheral, spinal, and supraspinal neurophysiological effects, right? Because in the previous episode, we talked about directional preference and does the exercise matter, right? That right in itself, adhering to McKenzie method is very biomechanical in its sense. But now, can we take that? Can we apply some of manual therapy here and begin to change the thought process of what's going on? Can we say, hey, yes, you do have pain moving in this motion. Let's utilize extension because we like extension for an HNP. But can I modulate your pain and then do the extension? Now what happens, right? Because then if we take it a step further and we start talking about Laslett and clearing the lumbar spine, Laslett says it before going to the SIJ to clear lumbar spine, you need to exhaust the sagittal plane with the McKenzie method doing press ups, because if there is presence of inflammation, it will elicit pain. So if we can use that as a pump, right, to get fluid moving and stuff like that, and it's painful, can I use manual therapy to modulate pain, go back and then clear the system, right? So we get very comprehensive in that sense. So that's my take on there.
Yeah, no, I think that's super important to have. And they even talk about Tuttle, which is a reference 16, 2009. He looked at some clinical decision making regarding manual therapy, and they gave a simple answer that he suggested: paradox to the paradox that we're currently in. And that was select an impairment that is important to the patient. Simple. Don't why are we making it hard? So yeah, I think it's super awesome that we were seeing this kind of shift in 2011.
Yeah, I mean, Tristan, and to your point, I mean, to what patient is pain not an important impairment, right? I think to touch a little bit on what Mike said before about the cervical spine thing, is that with the exception of analgesia, they're saying that it's the skin temperature and conductance that's very short-lived. Analgesia is up to 24 hours. That's very significant and not that short if you're in pain every day. That's the best pill I ever heard of, you know? And also, Mike, I'll raise you one further on that McKenzie directional preference connection because I think that was really important to make there. Well, why do press ups work, right? Beyond just the biomechanical nature of it. Well, if you're in proning press, it's like a PA mobilization. So, what is the neurophysiological effect of the McKenzie method? That also not insignificant. So, when you really understand what we're really doing, it all is part of the same umbrella. If you really look at the hierarchy of what's happening.
Yeah, and then you put a strap right on that area, and now suddenly you got an MWM, right? And we're talking about a joint mob
Oh yeah.
MWM, right? Oh, or we're creating some type of patient reliance on us. Not if I put a strap right on their back and say, hey, this is what you do when you're feeling a little flare up. And if it gets worse, maybe we need to look at some other things. We need to look at some load management, some biomechanics, some type of other type of manual therapy techniques to calm down the system. But we give them self-efficacy, and yeah, I think that was a credit to you making that connection, Darian. Because yeah, what is a prone press up?
But even so, we'll add even another layer on top of that, right?
Love layers.
Forget about the MWM, right? We have the argument with manual therapy that it's passive. Yes, manual therapy is passive. Loading starts on the table when we get them active. But to your point, Darren, if we just add a little more spice to it, can we give them a press up? How it hurts. Okay. If we adhere to biomechanics and we think that there's an issue with facet closing, can you do the press up while I do a UPA to that segment? Right? Now it's active and we're getting their physiological effect from them doing their own exercise because we know that doing exercising has pain modulatory effects, but now you're also getting a cascade effect from me putting my hands on you. So there's different ways to layer this, and for the people that are listening, it's we have the construct of how can we go above and beyond and think beyond that, and that's what I really challenge you guys to do.
Yeah, and I want you young clinicians right now to take a second look at the prone instability test and tell me, is that a prone instability test an isolation test, or is that a test that now you're pressing on someone in a P to A fashion and you're adding some neurophysiological input? Let us know what you think about that. As we head over to the limitations, I thought one of the most important things they said is that the lumbar spine was a region that was underrepresented and asymptomatic subjects were overrepresented. I think that's very important to look at. I think the lumbar spine is something that in physical therapy is of great importance, given its vast majority of how many people it affects throughout the year, how many people it costs for visits, and its cost on the healthcare system, specifically insurances. Anything before we move on to the conclusion, guys?
I think that's pretty cut and dry.
Yeah, so they kind of conclude here that only 2 studies examine the temporal nature of the NPE of the single session, right? Which makes the enduring nature of clinically important outcomes difficult to judge. So they do say it's difficult to judge at the moment, but they say research shows and demonstrates that after a single session of spinal joint mobilization, has been highly important to contribute the paradigm shift of how clinicians view technique, application, and outcomes related to manual therapy. Again, on a point that you made, Mike, here, I think it's that paradigm shift that was needed. It was something that we needed in the literature, and it was something that we needed in our field, and I'm so glad we got it, because it just gives us more tools in our toolbox, right? Anything you all want to add about the conclusion before we conclude this episode?
It's not conclusion, but I want to make this point earlier, and I slipped my mind, but I'm glad you guys brought that up because about being specific or not specific, on the top of page 3 of the PDF, under study characteristics, the first paragraph, it actually says that both studies involving symptomatic subjects demonstrated a significant reduction in pain with oscillatory mobilization of the cervical spine, although it was not at the correct level. So like I probably that a little bit, but they're essentially saying that you can still do the right thing and not do the right thing. And I think that's also pretty significant to point out.
Right, and
Yeah, I had that
that
scarred.
yeah, and that dives further into the, do we need to be as specific as possible? I would say no, and because that's what's saying right then and there, but it doesn't mean we start getting sloppy with our techniques,
Yeah.
right? We want to withhold a standard to our care and try to be as specific as possible, targeting the right segments, but know that it's manual's not as specific as we want it to be, and we can still achieve some of the same results mobilizing elsewhere, say upper cervical versus lower cervical, in terms of a neurophysiological effect. Tristan, any last comments before I wrap us up?
No, I think it was a beautiful study. I think it was a study that was needed in the literature, and I think studies now are starting to look at layering, and I think they should be layering our manual techniques and the effects of layering what types of exercises should be layered, what type of neuromuscular reeducation should be layered. So I'm really hopeful that the studies that are currently coming out in 2022 are going to address some of those questions.
Absolutely. So then that brings us to the title of our article, The Neurophysiological Effects of Single Session of Spinal Joint Mobilizations. Does the effect last based off of this article? Yes, it does. You'll get difference in skin conductivity and temperature lasting roughly 5 minutes, but the main thing here is that you'll get hypoalgesia and reduction of temporal summation that can last up to 24 hours. And within that time, especially within our sessions, we have to realize that, again, another recurring topic here that we've been mentioning is layering our treatment. Can we modulate their pain? Can we facilitate under-facilitated muscles, right? To then create a meaningful session and get them to exercise and get them to move, get them in control of their diagnosis and what may be going on. So with that being said, I want to thank you guys for tuning in, for watching this episode. I want to, again, thank Dr. Barrera and Dr. Fernandez for taking the time out here to discuss articles with us. And with that, we're going to conclude today's episode. Stay tuned for the next episode, guys.